Welcome to the digital podcast that explores how different organizations transform the way they create and capture value with digital technology. Stephen, welcome to the digital podcast. Thanks for joining me.
It's good to be on the show with you.
I'm really looking forward to our discussion. I mean, we've had discussions outside of the podcast about various things, primarily focusing on healthcare and how healthcare needs to be revolutionized, changed by more personalized applications. But first, maybe it would be good to introduce yourself.
Okay, so I originally started off as a pharmacist in the NHS, in secondary care in hospitals as a clinical pharmacist. So I used to give advice about which drugs to use on ward rounds. But I found myself a little distracted by the dispensing processes and ended up writing computer systems to try and get those done automatically with robotics and web technology in the early 2000s. So that's where I started and got into IT, as well as doing things in terms of pharmacokinetics and total parenteral nutrition, in the very early days of AI when it was called Bayesian statistics, which now would be the stepping stone into AI as naive Bayes.
Okay, thanks for that introduction, Stephen. It would be great to hear about Evergreen Life's history as a company, how it started, and also with what objectives before maybe moving on more specifically onto the Life app.
Yeah, so as I left the NHS, having done some computer programs within the NHS that were used by my colleagues, I started to learn about what was needed to mean that information was shared to enable us all to have a complete health record. And it sounds really simple to say, and it's hard to do. And so for some decades, I helped build businesses that were based on interoperability, and with combining that data to help to improve data at the point of care. The whole point of starting Evergreen was to say, well, how would we build a system if we were starting again? So I think we would all agree, wouldn't we, that healthcare at the moment is broken. Almost most things about it are. And I think as I started Evergreen, whilst it might not have been as clear then that it was broken, it was clear it was going to be. Okay, and there are various things that mean healthcare is in such a difficult position at the moment. One of them is our approach to aging. So we're getting older, but our health is getting worse when we're young. So we're increasing the number of years we need to look after everybody, which is increasing demand. The other thing is that when we do try and treat a patient, there's a lot of data stored, but it's not really made available at the point of care to improve somebody's health. And yet technologies exist to personalise healthcare that could make things so much better. We just can't get access to them because the data isn't there. So Evergreen was started to try and fix some of those problems. And it started on a new paradigm, one in which the person can own the record themselves, and that starts as they're born, not as they become ill, so that we can help with prevention, giving them information, helping them on a journey where they get sick later in life, but also helping the NHS have less people that demand services from them. Also then using that data to improve the efficiency of services should they need them. So both reversing diseases rather than treating them consistently as chronic diseases, but also helping pick the right drug from personalised medicine. So once you've actually got that platform with people on it, where they're using it for their diet and lifestyle to help them understand themselves with their genetics, personalising their healthcare, as well as their own well-being. So just knowing which exercises to do to mean they'll have a long and happy life. We'll have a complete health record. We do with Evergreen have a complete health record where today we've got 8 years of diet and lifestyle. 6,000 people have done a genetics test. And then 3 million of them are using the app. 1 million have actually got the ability to connect to their GP record and add that to the data set. So having a data set for you as a person, which includes your genetics, your lifestyle, and your medical data, is exceptionally valuable. But it also helps us all as a society to be able to do research on personalized medicine. To be able to take the advantage of personalized medicine, you need thousands of times the number of research studies that we did in the past when we treated on the basis of population. And so Evergreen's all about a new healthcare system where the data is owned by you. The health system can benefit from you having a complete record. And then research organizations can benefit from having people online who can offer their research for data, often with quick turnarounds and in small numbers, because that's what we need for personalized medicine.
That's great, Stephen. And you've touched on so many different points, right? From the struggles of the NHS and the overburden on the resources, right? Different types of resources, from human to physical resources that are used to, as you said, primarily treat patients that are in their elderly years or suffering from chronic diseases. And you took that and you flipped it on its head almost, to say that, well, we need to start early and we need to manage that from the day we are born, preventing disease as opposed to treating disease. And we can have a more extended conversation on that. But maybe before we do that, maybe you can say a little bit more about the types of solutions that Evergreen Life provides, both at the primary and secondary care, just to understand. I mean, you mentioned the personal record and the ability of patients to hold and to own their own data, which then allows them to move around the health system, right? As opposed to the health system having to worry about that data and then giving passwords and thinking, worrying about interoperability between systems, etc. You reverse that. You give that back to the patient. But maybe you can say a few more words about what kind of solutions you have for GPs and then for secondary care.
So possibly it might be worth unfolding those solutions almost from the beginning and taking them forward throughout our journey. So if you say, well, initially what we attempted to do, or and had done by the year 2017, was be able to put the whole of your health record on an app that you could carry with you wherever you went. So that's been a capability that's been there for 6 years now. But if I take an example of Margaret, who's one of our test patients, she was used the live version of the app, but she put all of her health records on it. She was from Greater Manchester, so she was a Mancunian, and she went to 7 different specialist hospitals over the period that she collated her record. She had a pacemaker fitted. She had treatment for a rheumatological complaint. She had her eye removed. They believed she had cancer behind one eye, as well as having problems with her breathing and ENT. She had a number of times had issues with blocked ears and in her nose. But it was only when she actually was being helped by one of our nurses at the time to keep her record right, and as a trial patient, I was called by that person and they said that Margaret is about to have a second eye out, and I'm very worried about that. So at the time we just said, well, why don't we just use the app for what it's for? Also give it to the carers. This is the very early days, remember. And so we put the app on the table for her multidisciplinary team meeting. And because they could see all 7 different things that she was being treated for in Greater Manchester, where the records had never been merged or shared previously, they could see that she only actually had one disease, and the 7 things they'd been treating were symptoms. So they gave her a biological to treat that disease, and she kept her sight for the rest of her life. She's She's died today, but if anything, she died of the treatment that she didn't need. So that's, I think, a really good story about that first stage of what we did, which is integrate the health record so it's there at the point of need. So today, people can take that app with them wherever they go, and they've got their whole GP record, lifestyle data, anything they want to put on there. There's a document management system, and they can use it for wherever they're treated.
That's great. I mean, and that's a heartbreaking story, and I'm sure you have many more like that. I mean,
Yeah,
these things shouldn't happen, right? These cases shouldn't happen. We should try to prevent
yeah,
these cases from happening.
yeah. That's right. But if you then sort of let that unfold a bit, I'll tell you perhaps a happier story, if you like. You mentioned how, yes, we do believe we should start at birth. More evidence is coming out, for example, that you have a different microbiome if you have cesarean section than if you have a normal birth. So just the first factor of when you're born. Now, is it treatment to think that we should think of doing something about that within hours after a baby's born to make sure that their microbiome is as healthy with a C-section as it is with a normal birth? I think the definition of when something's a disease and when it needs treatment is actually fairly philosophical, really. If there's something we know we can do better to mean that we have a better and healthier and happier life, we should just do it. Whether that's giving the right drug for Margaret when they knew, or whether it's enabling a C-section child to get the microbiome that they deserve for the rest of their life. Okay, so we think like that. We think about prevention, and so what we've done in the app is we've used AI to drive the right piece of reading, if you like, for our users. And it's now been live for 8 years of continuous data, and we've been able to put into that um, the data that people have put in when they've changed their lifestyle. So we can see things like um, people's blood pressures have dropped or not, or their blood sugar has dropped or not when they have changed their lifestyle. Now it's correlative data, so we can't say that it's causative. Okay, but one of the things that we found is that if a person had high blood pressure and they downloaded the app to use it, six months later, 60% of them didn't have it anymore. Okay, and their blood pressure had dropped by 19 millimeters of mercury. Now they're given things to read. We can't prove it's because we've read them. It's really hard to do that. But we just knew that if that happened in our data, that somebody was diagnosed and 6 months later it was down. Anyway, we've now taken over running 9 GP practices. We're responsible for NHS contracts for 100,000 primary care patients. And we went live with the software over a 3-month period. And we can tell you that the blood pressure was relatively static prior to that from the GP records that we can review the history of. And we can also tell you from 6 months after we decided to go live with the software, the drop in blood pressure was 19 millimeters of mercury on average across our patients. So what that's saying is, in terms of prevention, it's a lead indicator, isn't it, that we're going to get less strokes, less heart attacks, and probably less things to do with metabolic disease by lowering that blood pressure and lowering. We also found the same result in terms of lowering average blood sugar. What we're trying to prove is that we can reduce the demand on the NHS by being more like Sweden and Japan than we are like America as we are now, which is that we have 20 years of ill health here, whereas in Sweden and Japan, they only have 10. So that I think that there's a real positive use of it as well there from the next stages of what we did, which was start to apply it to well-being.
That's great. And I guess in terms of the actual app, you mentioned that you provide guidance and almost like personal nudges, right? Based on the AI prediction model, the historical data of the patient. And then you provide this guidance in addition to personal nudges on maybe you shouldn't eat that, or maybe you should take care of your exercise, etc., as a way of bringing down, changing behavior essentially, to bring down
Yeah.
blood pressure, to minimize blood glucose levels, etc., right? Maybe you can say a little bit more about that, because not everyone will be familiar with the Evergreen Life app.
So we're very, very cautious that we don't give advice as such. We don't tell people what to do. But what we do is enable them to get insights about the rest of the people that are using the app and what they experience, as one of the motivators. So, for example, um, I've forgotten the exact numbers, but roughly 20%. There's a 20% increase in your happiness score if you get half an hour outside each day. So if you've answered a questionnaire saying I get at least half an hour of being in the outdoors, the chances are you will be 20% higher on our happiness score. So by saying to people, did you know? So the ones who say that they don't go out, you just say, did you know people who do go outside get 20% more happiness? We think that's going to mean they're more likely to go outside the following day. And so we do see people change, and they change positively. So for example, during COVID, when most people were generally putting on weight, generally an Evergreen user lost weight. So their BMI improved. So we've got lots of early indicators that the reading that we give people and the insights, we call them, the insights about other people who are using the app as well, mean that they are more likely to do the right thing.
So you are, I mean, and this goes back to the point about personalized medicine and the focus on prevention, right? So, as you say, you're not giving advice. You're not a doctor. You're not providing medical advice, right? But you are changing behaviors by showing the evidence, right? You're showing the evidence, and then you also show great examples from representatives of a different age group or different demographic, to motivate this change in behavior. But I mean, from the patient side, I am sure there's definitely demand for this, right? I am sure people want to get better. What about the healthcare provider side? What kind of reactions and responses do you get from them when you're presenting this?
I would say the strategic thinkers are very, very positive. The problem you then get is that the system itself is not yet designed to work this way. So actually paying a company to mean that we don't need healthcare isn't something we do. Yeah. Generally, we only pay people items of service for people who are sick. Yeah. So I can tell you a very current story for us, in that we've been using our technology to help reduce waiting lists in dermatology. And the way that we've done that is by enabling a digital triage to be really efficient, to say to people, don't worry, you're okay. You don't need to come and see a dermatologist. Okay. But the problem is that most dermatology services pay you for each time they see a dermatologist. So as you can imagine, our staff are sitting there saying, how do we define the service? And it's very hard for them to resist saying, well, if we saw more patients, we'd get paid more. And what we want to do is make sure that we only see the patients who really need us, so that there's only 616 qualified dermatologists in the country. Well, if they saw every person who thought they had a skin complaint, we would never get rid of the waiting lists. So it's a really good current example, I think, of how the NHS hasn't yet worked out how to procure modern services that actually reduce demand rather than just serve it more efficiently.
Yeah, and I guess this goes at the heart of how public health services are funded, right? And I mean, if you're funded on the basis of how many patients you treat, then there's very little motivation to adopt these kinds of technologies. You're more inclined to
Yeah.
adopt technologies that enable you to treat.
So this is why we decided to start managing some of the services ourselves. So not because in the end we want to kind of as our business be the manager of health services, but just so that we could start to show what the art of the possible was, with customers who didn't feel free to do it, even though they might believe in it. So when we've gone live in our sites with these things, I wish I could take you there. They go from being almost a battleground in primary care, where there's a surgery I visited in Dagenham that we took over the management of, and when I first went down there, the queues outside went outside onto the pavement at 8 o'clock in the morning from patients. The the so the staff were, I'm going to just say it, close to tears in trying to resolve the incoming telephone calls. We had, I think, over 1,000 calls that morning from people. It's just impossible to meet it with the number of staff that could even fit in the building. Never mind the number of people you could afford. And so by putting in the process of digital triage, so allowing the right person to deal with the right problem, by using technology to send it in the right direction, but combining it with reducing demand by people being able to use the app for some of the things. They no longer even need to have an appointment because the app's told them the answer. So by doing all of those things, I can tell you, I visited another practice in the group. It was the same change that we made, and there was nobody in the waiting room at all when I went. And all patients who want to see a doctor are now seen on the same day. So we've moved our practices from having difficulty seeing somebody within 2 weeks to being able to serve every physical appointment on the same day. And what's more, the doctors choose to see 50% more of our patients than the patients ask for. So it's not by stopping those requests. We actually, by triaging, decide to see more than the patients ask us for, and yet we're as efficient as that. We're all convinced that the numbers that we're getting by changing to this model will be able to show to a health organisation that the savings are so significant, it's worth adopting this new paradigm. We're getting stats like in surgeries that adopt the way of working I've just described, their A&E departments get less people going to the A&E department. Think about it. Often people don't go for an urgent request to their GP. Sorry, they go to A&E because they can't get an urgent request at their GP. So we're having knock-on effects on the whole system by just putting the patient first, making sure that we use digital technologies to not do the things that aren't needed to be done, or making the admin people do it and not the doctors do it. All that type of stuff. So I'm absolutely convinced. I'm very optimistic that the health service will change and will realise that prevention, personalised medicine, pragmatic research done on your own populations, all of those things will start to deliver benefits. And even down to a subject we haven't talked about yet, but would be genetics. I absolutely believe that we'll do one, just as we'll check the microbiome as somebody is born, we'll be taking a genetics, a full sequence as they're born as well, to help them personalise their well-being right the way to personalising their health care in their later life. This will happen.
Yeah, and I guess we can talk about genetics later on when we touch on the different classes of technologies and how they are regulated. And I definitely want us to have that discussion as to what constitutes medical advice from a doctor versus what you can get from a class 2 technology. It's still not medical advice, but what you can get from the types of data that these technologies can provide. And, we can have a discussion about, what's accurate and what's not. And I know your views, but I think it's important for our audiences to also hear them. But before we go there, I want us to maybe um, talk a little bit about the business model of Evergreen Life in relation to getting this type of technology, this revolutionizing technology into the NHS. Um, as we discussed, it's not easy, right, to convince healthcare providers um, because of the way funding is structured and the way these services um, are provided, right? Both in the regional, within the regions, and across the nation. Um, and you talked about how convincing you can be once you're in, to show how you're saving resources rather than consuming resources, and then by extension, you're improving your revenue structure, right? But how do you enter, right? And I know Evergreen Life has been um, quite successful in um, getting the national contract for this application to be used across different GPs, right? But that alone was a big fit, right? There was a big success. How do you achieve that? How do you
Yeah.
take um, a technology like that to market within the NHS?
Yeah. So it's a really good question. If I try to turn it into simple fundamentals, um, I think we're all the same. I think we will think of paying for something that we want, but actually, a lot what a most successful businesses do is uncover a need, so that you sell to people's wants but deliver their need, and then you've got a customer for life. Okay, so the NHS is no different. If I take the progression from the very first application I wrote in the NHS, that total parental nutrition application, um, I initially entered the market by doing it for free and let my colleagues have it for free. I'm somebody, I now realise, I just want to see things change. I think of the social purpose of what I do, and the thought of waking up each morning thinking that anybody who's having total parental nutrition is having it calculated accurately and correctly and not manually, actually is the reason I do my job. But at the same time, what I realised is by having that approach, people decided to opt to take that module before they knew they needed it. And then it became, well, we all need that because the hospital down the road, they can do their TPN in an hour when it takes us all day to do ours. You know, and also it can be done accurately and it's repeatable. And that then became the thing that everybody should have um, over time. Well, the same thing that's happened much more recently to us in Evergreen, which is we realised that technology we've got is particularly applicable to dermatology. And the reason for that is that we're now using machine learning and AI. And during COVID, when people couldn't go to the clinics, they were taking photographs of their skin. So we could feed those photographs and their diagnoses into a machine learning engine. Now, do our customers realize that what they need is a digital triage that can reduce demand? No. But what they do want to do is get rid of their waiting lists. So that because we've got massive waiting lists for people on dermatology, as I'm sure you know. So in Doncaster, when we went there, the waiting list was 33 weeks. Today, it's less than 2 days. The way it was provided there was that we gave tools to the GP to take a better photograph. So we stuck to the single way that they still wanted it. They wanted GPs to refer to hospitals more efficiently. But actually, if you said, what do you as a person need? I'm not sure you'd say, I need to see a GP who's going to tell me I need to see a dermatologist. But I don't think we'd say that, would we? We'd just say, I want to be able to send a photograph of what's wrong with me and know whether I've got to see somebody who uses a knife or something that means I have to go there physically. If everything else could be done on the app, that would be great. Yeah. So that's what we believe the system needs. But where we've got to now is we've just won a contract in an ICB to do the whole of Lancashire and Cumbria where we are the primary care triage, as well as the service that delivers the dermatology physical service. So we're already seeing the market change to understand its needs because we started to deliver them. So a lot of people in the NHS who are technologists bring tech looking for a problem and expect the NHS just to adopt it. But they don't. You have to work the other way around and deliver what they're really wanting. Throw in the needs for free. And then from then on, you become the new standard.
That's a great way of describing the process, and I'm sure there's ups and downs, and I know we've had discussions around this before about how should startups, digital health startups, take their applications to the NHS, and I did plan to go through through four different areas, but I mean you've already started breaking those down, but I don't know whether it's worth us going through those. The areas that I had in mind was obviously defining the application and then developing the business model for commercialization. Before then addressing regulation and then scaling up. So it's those four areas. And maybe just building on what you just said, defining the needs or identifying the needs that you can serve as opposed to finding a problem to solve. Which I guess in a way it's the same, but it's more nuanced in the sense that maybe those needs are not identified the first place, even though there is a problem. I mean, the example you gave earlier with the patient that, doctors thought that there were different problems with her, but in fact, those were just symptoms of a single problem. I guess we can think of needs in the same way that, there is an underlying need that is really hurting your business or your service. And you're trying to identify problems that are perhaps peripheral but not central to solving that need. Maybe that's the way that I interpret the way that you explained it. Now,
Yeah.
I guess just to break that down a little bit more, you will have entrepreneurs, and those entrepreneurs come from either the medical side or they come from the technology and business side. And very often, the entrepreneurs from the medical side may not understand the business model or may not understand the technology very
Yeah.
well, and vice versa. The people with the technology and the business model don't understand the medical side of things. Can you give some examples? Because obviously, beyond we should mention here that beyond your role as a technology entrepreneur and a digital health business owner, you are also you've sat on a number of funding bodies as a chairman and as a board member. So you've seen a lot. That's what I'm trying to say. You've seen a lot of examples. So maybe you could give us some examples.
So yeah, an example that springs to mind. I'm also a business angel for some health tech startups, and a guy from Watford, he'd done a small, like a lot of people do nowadays as part of their course, he'd set up a very small business, if you like, and at the time he had a wooden mannequin doll of a hand with some strings on it and some stepper motors attached to a piece of wood at the bottom, and he said, "Look, I can make this hand move like your hand." And he put a strap around my arm, and as I moved my fingers, this mannequin of a hand moved the same. And then it dawned on me what he was trying to say, and that is that if you had your amputee, then you could put an artificial hand, which would have full movement. Okay. Now this was an engineer. He'd done an engineering degree at Watford, not a clinician, and didn't understand the commerciality of the NHS. And he went on. The company is called Open Bionics. If anybody wants to write it up, I think it's a fantastic company. His ambition was to be able to use your camera to do a 3D image of your stump, to do a remote order for a bionic arm, and therefore be able to serve places like Africa, where there are more amputees than there are in the UK. Anyway, he got to the point where he wanted to get an NHS contract for it. And he rang me up very frustratedly and said that they were about to be eliminated from the procurement process because they had full digital movement of all of the fingers and the thumb. And the contract and the product that the NHS was looking for was one that only did a single movement of in effect, all fingers moving at once and holding something. And so he thought he was going to be he wouldn't be allowed to go. So I just said, well, it's really easy. Go back to that, deliver to what they want, and then, sell to what they want, and then deliver to their needs. I said, the thing to do is put a software switch in it so that you make it so that it will only hold for when you sell it. And then you do an education piece to all the physiotherapists saying there's a switch in the arm. If you want to turn it, it'll give you full finger movement. So I haven't caught up with him since that, but I'd love to believe that the NHS will change their spec to being bionic arms should have full finger movement. Because if you did go on to watch the videos they've taken of people using these arms, they've become exceptionally functional. They've got people who are riding bikes using the arm to stabilize them. So this is an amazing company that's going places, and I would like to believe that as a small shareholder from the beginning, I've helped them with that type of advice.
The open bionics example is quite interesting, and your advice on downgrading the technology to fit the needs of the NHS is quite interesting, very insightful. Can you elaborate further on how aspiring entrepreneurs should pitch their technologies to the NHS? Where should they start, and what should be their target?
Yeah, so the first thing is to identify that want that they will pay for, and that's usually reflected in either framework contracts that you could go for, or maybe things that particular hospitals or organisations want and are tendering for. Okay, now those are spot the trends in those, because you'll never be able to develop your software or your technical solution quick enough to respond to something once it's come out to tender. So you would look for a particular problem that people are wanting and prepared to pay for, and then the bit I really love about this, and I kind of want to make sure people understand this, is that ultimately that need, I like to believe, I'm a bit of a romantic, I like to believe that is always what the patient would ask for. It's always that fundamental need of a human being to be well, okay, and get good healthcare if they need it. So it's not always what they want and are prepared to buy. But if you know that you can deliver it with something that exceeds that expectation from the tender and that declared want, you've probably got yourself into a market where you can be really successful. Yeah. So that's the way I would start. I'd look for something that people are saying they're wanting, that they will pay for. I would then look for how you can do something that's really in the interests of patients and is so much better for health and healthcare, and has some social impact in when you do it. Maybe it's good for society, it's good for the person. And that's really the underlying need of healthcare, isn't it? That's what we're all really trying to do. And so if you can then underpromise by promising only to deliver the contract you get paid for, but you overdeliver in terms of giving them the functionality that means a patient is more well, or gets their care better, or society benefits from what you do, then you'll be in that market for a long time and be very successful, in my view.
And that's a great quote right there. How to sell to the contract, but then over deliver to the needs of the patient. So now, just to move on to the next point, which is commercialization, right? So you're in. Once you're in, then you need to start making some money in order to be able to become sustainable, right? So what are some of the challenges of commercialization in the English NHS, and how would you compare that with the private sector? What are the key differences?
So the NHS is almost defined by always doing the right thing. So in other words, it will make sure that it's going to first do no harm, basically. So a lot of the systems that are in place get changed very rarely and are usually out of date that you have to work with. Okay. Now you can come up with all sorts of other reasons why that may be, because a lot of money has been spent on IT over the years. A lot of it hasn't been delivered, and what has been delivered is now very old. Okay, that then makes it hard for you to fit your new shiny thing into the way that the NHS software that's used on a day-to-day basis is then used. And I wouldn't underestimate the costs of doing that for your customer. You'll need to be accredited for any of the interfaces that you need to use to make your product work. You'll need to make sure it's regulated as well, which is also costly to do. So there are people who come in who are technologists who start off just believing that anything's changeable because it's software. Actually, within the NHS, you need to budget for those things which the NHS stipulate have to be done. And in some cases, there's no way around that. If you go into private, clearly they have their own systems. They'll have their own constraints from previous decisions that they made, but they are much freer to do their own thing. Generally, they'll tend to try to spend less, ironically, because the NHS, I would say, it spends a higher amount of its percentage of its expenditure on IT than the private sector does. So the private sector does insist on value for money in a way that the NHS doesn't.
And I guess that's the huge difference and a paradox almost, right? That one is willing to spend more, perhaps on things that seem to be ideal and doing no harm at first, but in the long run, you actually generate more problems, right? Things like creating systems that don't talk to each other, or they are implemented in isolation, and then you have to find ways to make them interconnect. I mean, that's a problem that I've seen in many different cases, and it's almost against the do no harm. I mean, you do no harm to the patient, but you do harm to the system.
Yeah.
And your point about regulation is an interesting one, which is my next question. I mean, in the UK, we have medical devices regulation, right, which includes UKCA and CE, and then you have also UKNI and CE, which each with different constraints, right? And this also applies to software and including new AI systems. Can you, from your experience, can you help our audience understand the process of achieving such marking? What does it take, and what are some of the challenges to achieve such marking?
Yeah. So first of all, to say that the only device I've had as a medical device would be that TPN example, because clearly that was doing prescribing and it was doing automated dispensing. So that's the most highly regulated piece of software and technology that I've been involved in creating with a team. Today, we did get Class One medical device status. And all I would say is that the whole field around the application of AI in health is changing all the time, even to the point that we no longer really need Class One to be able to do the things that we do. And with the adoption of CA marking, which I think is more of a response to Brexit than it is solving the problem, which is let's lower the hurdle and make it okay in the UK, to try and get innovation to happen in the UK. It really doesn't help people who then want to export what they've done, because people in other countries see the CA mark as that. They see it as something that is of less quality rather than of greater quality. So it's an emerging field. For those who are listening who don't realise this, the CA marking issue is a relatively recent entrance into this confusing area of developing medical software. So what we attempt to do is be decision support rather than decision making in what we do, giving people things to read rather than giving them diagnoses or advice. So we ensure that currently that what we actually are delivering doesn't need to be a medical device. At the same time, we are developing medical devices. So as soon as we take to market the ability we've created to diagnose skin cancer, for example, that will need to be a class 2A medical device.
And in previous discussions we had, you argued that this class 2A technology should be able to provide as competent, if not better, recommendations than doctors.
Yeah,
And I guess the point is that if the accuracy of that recommendation or prediction is as high as those of doctors, right? Maybe more than
yeah,
90%. Then you get into this discussion on what is objective and what is subjective, right? What is
absolutely.
accurate versus what is based on intuition and prior experience.
Yeah. The first thing to get your head around is the fact that whether it's a computer or a doctor, we've never imagined anything that can be 100% accurate. So therefore, there'll always be a person where this has gone wrong for, and the consequence to a new technology of that happening is far greater than that happening to a current medic. So if a person misses the diagnosis of a cancerous mole, it seems human. If a new diagnostic tool misses the diagnosis of a cancerous mole, it's seen as a fault in the system. And actually, what we're attempting to do with AI is to just be better than a doctor. We can never be perfect. So therefore, if you combine this with commercialization and being a company providing these things, you become very cognizant that you are needing to be a lot better and demonstrably better than the current systems to be safe in that market, both obviously compassionately and ethically, but as importantly, commercially. If you look at some of the things that have been brought to market, and I'm sure Babylon has to be a really good example of this, where it is, in my view, brought to the market a little early and had faults. And the company really suffered from that, not from a medical device point of view, but from an external market perception point of view, in that the product simply didn't work in a very dangerous area of healthcare. So that was how it's perceived, and perception is as important as medical device. And all I would say is that, keeping it really simple, we need to make sure we build things that are actually better than the current system, not just as good as, but better, and make sure we can prove that before we launch them.
It's a point about accountability, right? Being accountable to the decisions being made. And as you said, if it's a human making that decision, then the human becomes accountable. But we tend to accept the fact that humans make mistakes. And there's some literature that says that, well, they do make mistakes, but they learn from their mistakes and they improve. Whereas there is a huge literature on algorithm aversion. And that literature talks about, how humans do not perceive AI systems to be able to learn from their mistakes. And I think that's where it lies, right? It lies in that issue of we cannot hold them accountable if they start making errors, because that's a problem in the system. That's a problem in the design. And the designers need to go back and fix the errors. But there's a whole issue there that in the perception of the market, then you lose face, right? As you said. But what you're saying is, if we are going to develop systems that augment and potentially replace, they need to be
Mm-hmm.
better than what we already have. And
Yeah.
maybe you can also comment on the accuracy in relation to the types of data that we use to make those decisions, in comparison again to what a doctor has at his or her disposal when making those decisions, right?
You're covering a lot in what you talk about in terms of which technologies you then choose to provide a system in health. Generally, what people are doing is they're using machine learning in a dynamic environment while they develop, to create an algorithm which is then consistent as it's used diagnostically. And obviously, to create a system that would learn whilst being used is possible. And I think it would be a brave supplier that decides to do that. In going back to that perception argument, and even if you take the creation of an algorithm in a dynamic research environment, often people are building their AI based on data that's been done by others. So just like the in research, we're used to looking at previous papers as foundational principles and then do our next piece of research. People are doing the same thing with AI. The problem comes in with exactly the way the data is created and collected, and whether or not the circumstance is the same. And so can I bring a real world example of us doing that, and you'll see what I mean.
Yeah, absolutely.
Yeah, we're developing with with UCL an algorithm to help people choose the right monitoring of a person who's on chemotherapy. And what we want to do is minimize the number of times they need to have a blood sample, which of course is intrusive to their life. So we've got a model and it works at UCL, and they are now putting it into clinical practice as decision support and observed by a clinician on every occasion. But we've managed to actually get it to being a very useful tool for them. This is still in research, and then they went to the other main cancer centres in the UK and applied the same logic to their historical data and found that it actually wouldn't work, even though it's based on exactly the same inputs. Now, it takes a clinician who understands the way that chemotherapy is prescribed to know that each of those departments actually take the same prescription, for example, of chemotherapy and serve it in a different way. So right down to the detail of some oncology centres use dose banding. So nearly everybody gets a dose per kilogram of certain drugs. Some hospitals will give exactly the right number of milligrams, perhaps to the first decimal place of number of milligrams or micrograms. Whereas other hospitals will say, well, we'll just have a 50, a 60, and a 70 on stock, and we'll give the nearest dose. But they both say that they're using the regimen of a certain name, which is stored by the machine learning when it's first learned and taken as an input in the algorithm when it's created. So we've now created something which we know will work at UCL, and we've now proved it won't work anywhere else. So what that shows you is that some of these things that are created are circumstantial, you could say, but there's certainly a lot more going on when you use a static system like that. If it would be possible to build something that you could give to each of these hospitals and would then, in effect, learn on the job and improve over time. But in the medical world, I am going back to that perception thing. If you're a supplier who does it the first time and gets that wrong, you won't exist the following day. So it will happen one day when we get real time learning. But today, the way this is all done is by using machine learning in the lab, if you like, and then providing an algorithm that has to be better than a doctor as a static diagnostic tool.
So what you're saying is when you're trying to commercialize a technology, whether it's in the public sector or in the private sector, there are no second chances. You need to get this right the first time, exactly because there are no opportunities for real-time learning as you would have in a research environment. And that's very interesting. And obviously what you are describing in terms also in relation to the data, right? That the data is very specific to specific organizations, right? The same, so the same algorithm would not work, as you said, in a different organization because there are fine nuances, right? Potentially even also dealing with different cases of the same medical disease, right? Not only the fact that they are perhaps prescribing drugs very differently, but also perhaps that they're dealing with very different medical diseases. I
Yeah.
see that you
It,
want to say something on this.
yeah, yeah. So it's not that the system can't learn; it's that the system has to learn um, in an environment which has no impact on an intermediary failing. We have also developed a diagnostic for moles, or whether they're cancerous or not, and we're getting a really much better than a doctor on that one, and that's using a camera, taking a picture, and being able to say whether that's cancerous or not. And what we're doing with Scotland, we're being funded by an SBRI initiative to take all the historic data from Scotland of pictures that they've taken and the diagnosis that they've achieved and check whether or not we get the same results. So we don't have to do it at the clinic, letting it learn one by one and then make a mistake and then get it right and then make a mistake and get it right. We can take the whole of the data for Scotland since they had images and train the system not to make mistakes. But the benefit of doing that is in doing that we can test whether the output really delivers something that's better than a doctor before we launch it, which comes back to medical device standards. So it's not that the system doesn't learn from practice; it's that the way that you learn from practice needs to be a first do no harm way. You know, getting it wrong because it's very young in its learning, and somebody dies and saying, "Oh, that's okay. We'll wait until next week when it's better." That's not acceptable. So you've got to think of ways of helping it learn while you're keeping it for real use until it has learned.
Yeah, yeah. And just to add something else in the mix here, during COVID, some hospitals around the world were using federated learning to learn about different vaccinations for patients and their side effects, right? And they were using machine learning to understand the different side effects in the process of building new vaccines. And what's interesting there is that because of the nature of the crisis and the numbers of cases that were happening every day, the application of federated learning, where you have a global model that learns from various local models from hospitals across the world, was beneficial because of the nature of the crisis and the fact that there was an urgency to find a solution to this problem that did not exist prior to COVID, right? And as you said, there was more flexibility in accepting the fact that there are going to be losses, but we needed to do something about it. The urgency of developing a solution, that was an opportunity to use real time learning across sites. But I understand the point that when you're dealing with cases on a more routine basis within individual hospitals, this becomes very problematic because obviously you're dealing with the loss of life and you cannot wait until next time.
I think the subject you bring up there is fascinating because our approach to research and our approach to medicine, and dare I say it, our approach to common sense, changed entirely during the period of the COVID pandemic. Now, we were we used our machine learning capability to predict the from the behaviors we were recording on the app. I should say at that time we had about 700,000 people using the app, and we asked them all whether they were following government guidance and what they were doing, and then also asked them about their symptoms. And what we were able to do was predict how many beds in hospitals were going to be needed in advance of them being needed to help planning. And we did that by giving our data through to the government through Cobra and also locally to Liverpool and Manchester. So we were one of those able to use machine learning and AI prediction of those types of things to help in that, and got quite close to what was going on. But all I would say is that some of the normal practice that we are now gaining in the use of data wasn't followed in that time, and that could create confusion as much as speed. A quick wrong answer is worse than no answer at all, in my view.
Yeah, and I guess that's what COVID gave us, right? There was an opportunity there to innovate at a scale that is not possible in normal times, right?
Yeah.
And because of the
It's
urgency, because of the lack of solutions
mm-hmm.
to the COVID pandemic, there was more
Yeah.
experimentation and, by definition, more learning.
Yeah, and there's definitely no way that we would have been where we are as a business today without COVID occurring, and without us getting that opportunity. You know, it does show what technology can do. To think that a company as small as we are in comparison to the government and the whole of the NHS, we're in a position that we had more data than the government did about the spread of the disease early on. That was their words to us, by the way. And that's because it just shows the power of machine learning and AI, that getting right, consistent, accurate data is more powerful than in that circumstance than deciding to do something prospectively because a problem's arrived. And that's why I certainly believe having people on a consistent platform in the way that we did is far better than having a federated model. And the because the issue is that in the federated model, the way the data is collected, right down to the units it's collected in, is going to be disparate. And the danger is you think that data elements are the same when they're actually different. And so for this type of work, taking the data from a federated model, I believe is going to be found wanting.
Right, right. Very, very interesting observation there. And again, different circumstances demand different approaches. But as you said, the opportunities from such a major crisis were startling for at least for some startups, right? And I want to maybe focus now on the point of scaling a digital startup within healthcare in normal times, not during crisis, but in normal times. So, and I'm sure you've come across many initially successful startups that received initial funding. They had some implementations, they piloted, they had some revenue perhaps, but then failed to scale up. So,
Yeah.
what are some of the challenges of scaling, and what should startups do to address those challenges?
Yeah, this is something I became particularly aware of in terms of a scribe, where we were buying businesses who are almost at that stage where they maybe had a great product, they'd proved it, they could be about to go, or have recently tried. And at the time, the Americans had a great name for this. They called it the Bermuda Triangle of business growth, which where lots of companies get to this stage where they've got a fantastic potential, and then for some reason they just sink, die, or disappear. And so I think there are a number of things going on. That the first one is the general management of any company. As soon as you go from the point where you're simply managed as a tech, maybe you've usually got a tech innovator leading it, and they're not always the best managers, but they can manage to tell people what to do up to about 20 people, and you know, some even manage it up to 30. Um, but what you then need to do is develop a different management style of managing people who manage people. Well, that's actually quite a step change and a different paradigm for most people to do. And that's why I would say that's the biggest reason I have seen why tech companies can't scale, is that the principal has difficulty managing people who manage people. And if you were to read books about Steve Jobs or Bill Gates and look at Elon Musk, you'll realize that they have found ways around it, but they're not necessarily going in a straight line to get there. Each of them. Um, the second thing would be the way that the market perceives you and the products that you need to have. You know, being a trendy young startup with something that might fail, you're put in a place where failure isn't really going to be that consequential. But if you become the owner of a technology that needs to scale across the country, which actually has got some below the waterline problems if it does fail, then the way you deliver has to also change, and you need to professionalize the way that you do that. And that's got a whole subject in its own right. But that's the other side of things. Everything from some companies simply writing the software for individually for every customer that they see, and then having to maintain it afterwards. Clearly, it can only survive up to some tens of sites. You can't get to do the whole country that way. Nobody could do all 7,000 GPs if every GP had different software, for example. It's that kind of example, and it's the way that the system is architected, the way you implement it.
So organizational structures and standardizing the technology would be two major factors to success. And you're absolutely right. This applies not just to health, but to other startups, right?
Yeah.
The way they grow and they scale has to incorporate these two dimensions. So, in closing, I wonder whether you have any broad advice you can give to aspiring entrepreneurs as we verge into a new era of digital innovation and AI, and obviously with ChatGPT type of technologies or LLMs coming into play, and a lot more regulation with that. Um, what should we look for, and what should aspiring entrepreneurs try to do in entering digital health?
If you're an aspiring entrepreneur entering digital health, what I would say is that you're about to enter the most exciting era of this technology and business. Okay. When have we seen before the computing power that's required to do AI increase by 10,000 fold in 3 years? When have we been able to do things today like we can do today ever before? We can now imagine a situation where all of our data can be looked at via in real time prior to us making any decision about our health. And also we can imagine collecting the data, which includes genomics and our lifestyle and our health record, and having it all there, and knowing that the computing power is capable of delivering it on a mobile device that we can carry anywhere in the world. Well, we're in a new era. We're in an era where if you're about to do this, it's probably, I'm bound to say this, aren't I? It's about the most exciting market you can possibly be in. But don't go into it thinking you'll make a quick win, because you won't. Nobody makes a quick win in health. What you need to do is to know it's going to be hard graft, hard work, and it's the most exciting thing you can deliver with the greatest reward when you do.
What's really challenging in healthcare is that it's a regulated sector, right? It's not like any other sector where you develop the technology, you implement it, and you can immediately commercialize and scale very quickly, right? Every time you go through a hospital, a GP practice, a medical center, you have to go through hoops of different types of regulation, different ways of handling data to meet the privacy and ethics committees requirements, etc., that create all sorts of challenges, right? So, and I guess that's what you are pointing at there, that it's not easy, it takes time, and all the things that we talked about, being accurate and accountable for the decisions or recommendations that you make through the technology contribute to that.
That's right.
Stephen, it has been a pleasure, and I'm really grateful that you were able to come to the podcast. I've learned a lot from our discussions, and I'm sure that our audiences have also been more educated through this discussion. Thank you so much.
You're very welcome. I hope some people find it useful.